My name is Harris Foster. I'm a professor of urology at the Yale School of Medicine. We are doing cystoscopy in a male. We just entered into the penile urethra. We're going proximally, at which time we're now entering the bulbous urethra. Ahead of you, you can see the external sphincter or membranous urethra that we're traversing at this time. We are now in the prostatic urethra, looking into the bladder through the bladder neck. As we pull back, you can see the two lobes of the prostate and just a little bit more distally, the verumontanum. This is an important structure when we do surgery on the prostate. We are now looking at the bladder, and we'll search for the right ureteral orifice. We will then cross the trigone and visualize the left ureteral orifice or ureteral opening. What you just saw was a squirt of urine out of the ureteral orifice. We are now going to do a bladder survey, looking for any bladder pathology, such as bladder tumors. We also note that the bladder is somewhat trabeculated due to detrusor hypertrophy, with periodic thickened bands of bladder muscle or detrusor muscle showing through the bladder epithelium. The air bubble is at the dome of the bladder, and the air gets into the bladder once the scope is inserted. Again, this is trabeculation of the bladder, a little bit of erythema on the posterior wall. And we see that there is no significant pathology. We are now withdrawing the scope through the bladder neck or the internal urethral sphincter. The prostatic urethra is a little bit more dilated now because the bladder is full. However, you can still see two lobes of the prostate and the verumontanum. We're coming through the external sphincter or the membranous urethra. And now we are in the bulbous urethra, pulling out into the pendulous or penile urethra. Some of the material you see floating around are desquamated epithelial cells. The urethra is otherwise normal.